Good morning, everybody, and thank you for giving me an opportunity to speak today and to meet all of you. This has always been a great source of pride for me to see all these senior nephrologists who, in my dreams, I would not have met if it were not for this platform. So hopefully, if I make a trip back home and I'm in one of these South Indian capitals, I can hopefully meet some of you all. So the topic that was given to me was to discuss about bleeding cessation if you have bleeding from after you place a tunnel dialysis catheter. And so let's go and let me do this. All right. So usually you have seen that after you place a catheter, you may have bleeding. Now, this bleeding can happen immediately on the table, which is a good thing because then you can figure out what you need to do to stop. The problem becomes if the bleeding is delayed, and this typically happens. Everything is good. You place the pressure dressing. Patient goes home, is on dialysis, and now he starts bleeding, and unfortunately, you are nowhere near the patient. So whenever you evaluate these patients, there are a couple of things that you need to do. The first step is to figure out where is the bleeding coming from. We all know it's coming out through the exit site. But from the venotomy all the way to the exit site, there are potential places or potential etiologies for bleeding. So the commonest thing that we do is we all assume that the bleeding is from the venotomy. And as Dr. Kasi has said, the simplest thing to do, which all of us do, is to place pressure over the venotomy site. It's easy for us to say we are nephrologists, but in our hospital here, and especially if you have medicine residents who are taking care of their patients, they unfortunately don't know what it means to say when you say pressure at the venotomy. They will put pressure at the exit site and hope the bleeding will stop. And unfortunately, it does not do that. So if you have trainees, I think it makes sense for them to know where is the venotomy and where is the exit site. So yeah, the simplest thing coming back is to place pressure on the venotomy and see if bleeding has stopped from the exit site. If bleeding has stopped, then the source of bleeding is the venotomy. But sometimes the bleeding does not stop. You place pressure at the venotomy and yet bleeding continues. That means now the bleeding must be coming from the tunnel. And the simplest thing that you can do is to run your finger along the tunnel and keep compressing and watch the exit site to see if bleeding has stopped. So if you place pressure, say, midway down the tunnel and the bleeding has stopped, then you know the bleeding is coming from the tunnel. And the bleeding happens because there are small blood vessels that you cannot visualize that have ruptured and have caused bleeding. And this is something to always bear in mind, especially if you have somebody who's had central vein stenosis and stuff like that, and you're trying to place catheters. We all know dilated chest veins appear on the thorax. So there are some of these veins that you may not see. Sometimes they can happen in normal patients as well, that small capillaries or small venules break when you make the tunnel. So this can be a potential cause of bleeding. And the last thing that we should not forget is bleeding from the catheter itself. I'm sure none of you have seen this, and hopefully this is just a rare thing. And the classic story is every time the patient gets on hemodialysis, the bleeding starts. And so the way to evaluate this is to stop the dialysis and do a catheterogram where you shoot dye through the catheter and you're looking for extravasation of dye through the catheter. All right, so if you have somebody with a bleeding tunnel, what is it that you're supposed to do? The first thing that you're supposed to do is put the patient in a semi-seated position, also known as the semi-Fowler position, where the patient is between 45 to 60 degrees with the horizontal. And the idea of doing this is it lowers central venous pressure. And so if the pressures are low, hopefully it's easier to stop your bleeding. The next thing is also always to prevent or to restrict movement of the arm or the thorax that is on the same side as the catheter. Because if you place pressure and let's say there are bleeding from small capillaries, and every time you start moving that shoulder, then those capillaries will re-bleed. Whenever you evaluate this patient, it's very, very important that the patient wear a mask, you wear a mask and use a glove. Because I've had a number of cases where, initially when we were younger or when I was a fellow, and we would just rush to the table to stop the bleeding, I didn't realize that we were actually causing infection. And so this infection will happen wherever blood accumulates. So if it's coming from the exit site and you're breathing on it, then you're going to transfer MRSA to this site, and it can be a source of infection, and you can lose that catheter. And so every time I have a case like this, I will prophylactically give the patient some vancomycin just to cover for possible infection. Because whenever you see these patients, you're not prepared. Everything is done possibly at the bedside. And so there are, it's not in the control situation of your intervention nephrology suite. And therefore, there is a high risk that you will pass on infection, and you don't want to do that. So we already know about this. If the bleeding is at the venotomy and you figure out it's the venotomy, and even if you have not, first thing you do is place pressure on the venotomy. And sometimes we give tranexamic acid, which is a 1,000 milligram IV bolus. This is an antifibrinolytic agent, so it prevents fibrinolysis. It's very good for patients who are cirrhotic and stuff like that, because in those cases, patients, they have a lot of fibrinolysis going on. And so tranexamic acid is good. We use it so many times when you have bleeding from the exit site. If you place a PD catheter and there's bleeding at the exit site, we give pressure, we put pressure dressing and we give tranexamic acid. If the bleeding you figure out is from the tunnel, then you can place the BOLSTER dressing, which I'm going to talk about. And then if nothing else works and you still bleeding and there's still bleeding at the exit site, then along with pressure at the venotomy, you can put a first string suture at the exit site, and this will usually stop everything. The other things that you can do before putting the first string suture, you can inject thrombin. You can apply gel foam to that area, or you can give tranexamic acid. But I think the answer here, because thrombin, gel foam, tranexamic acid are all expensive, is simply to go ahead and place that exit site first string suture, which will most likely stop your bleeding. So what is the definition of a bolster? So as you can see in this picture, it is nothing but a roll or a cylindrical pillow or a bed that is used for support. And that's exactly what we're going to do. We're going to take a dressing and make it into this little log and use this over the tunnel to stop our bleeding. And so the definition of a bolster dressing in medicine is basically you're using a dressing, which is gauze, and you're suturing it to the skin. So this is known as the tie bolster dressing, TIE, as because you're tying a suture material to hold the dressing in place. And so since you're placing this over the tunnel, it serves two purposes. A, it holds the tunnel dialysis catheter in place and prevents movement of the catheter within the tunnel, so you don't tear or you don't reinitiate bleeding from small blood vessels that are ruptured within the tunnel. And the second thing is, because it's placing pressure or it's causing compression, it will prevent the accumulation of hematoma or blood in the soft tissue area, because as you know, this is a potential space where bleeding can, even though you put the tie at the exit site, let's say you put a suture at the exit site, the tunnel is still a potential source where blood can accumulate, and this will be very painful for the patient. And this is typically seen more than in the upper limb, it is in the lower limb, because in the thigh area, a lot of fat tissues there, patient is moving his leg, everything is moving, the catheter is moving. So here will be a good site where bleeding will accumulate, or blood will accumulate, and it will be very painful for the patient. So you want to avoid that. So let's look at what the bolster dressing is, and this is a simple diagram. All right, so I hope you can see my arrow. So here's the tunnel, and you can see here's the log of the dressing, or dressing that is in a fold, and 3 sutures have been placed, 1, 2, 3. And what you're doing here is a cross section. You're taking the suture, passing it under the catheter, bringing it out again, bringing it out again over the gauze piece, and just making a knot. It's pretty simple, okay? So I'm just going to show you the videos of how I do it. So the first thing I'm doing here is I'm taking a 4x4 piece of gauze, and I'm going to turn it into a log, a small cylinder, not a log, but a small cylinder, just like that. That's what I'm going to do, okay? So that's me, and I've made my little log. The next thing I'm going to do, is I'm going to go ahead and inject lidocaine on the patient. So here, this patient had some bleeding from the exit site. He's on the table. So you will classify this as immediate bleeding. Okay, so as you can see, I put my lidocaine on either side This is the worst part because patient gets additional sticks, but it will save you a lot of headache. All right, let's see here. All right, the next step is to place the sutures. So I already placed one set of sutures, and you're seeing here how I'm going under the catheter and getting out my sutures. So here I put 2 sets of sutures, and you can see this second set of suture that I'm putting, second set of sutures, you want to put it as close to the venotomy as possible, if it's possible. Okay, please try to do that. I've done this with 1 suture and it did not work. I've done it with 2 sutures. It did not work until I figured, try to make it as close to the exit site as possible. That way, you will really stop the bleeding. All right. So once you do that, you go ahead and you place your gauze piece that you've made into a little cylinder, and then you just go ahead and tie over it, as here. So whenever you pass the needle under the catheter, you will feel, if you hit the catheter, you will feel it. You will know you're hitting the catheter. So in all probability, you will not hit that catheter. So make sure you take a curved needle, which is slightly bigger, not very small, which has a larger radius, so that you can pass it easily under the skin and get it out. I wanted to use what is known as a 0 Vicryl needle, which is a very, diameter is about at least 2 centimeters, and it is a huge needle. It's easy to see it, but unfortunately we didn't have it, so I had to use a very small needle. But either way, you can still use whatever you're comfortable with, and then pass it under and put your stitch. So that's what we've done. So here we put 2, all right. All right, so we've made the bolster dressing, okay? And now over this, I'll place some tegaderm. I'll place tegaderm over it. And once you place your tegaderm, okay, so this, what I'm putting here is called a biopatch, because I remember I told you about infection whenever there's bleeding. So a biopatch is antimicrobial impregnated or a piece of chemical that is to this small, I want to say small piece of foam that you put around the exit site, and it helps prevent infection. And so this is the transparent dressing I've put over it, and we take it out, and this is what your dressing will look like at the end of it, okay? And so this is the ultimate thing. And so I take out this dressing at the end of 2 days, and the way I do it, you can see the sutures. You just pull the suture up towards you, and it'll make a small little, give you a small little space to go under that. You can pass your scissors and just cut it off, and you're good to go. So with that, I think I come to the end of my presentation. Thank you.
Thank you, Adrian. Any questions from the audience? What is the size of the suture you use, suture material you use?
Yeah, so here I've used 20 Vicryl or 20 Ethelon. If you use absorbable suture, that's actually the best, because patient will go home with it. Eventually, it will fall off in 7 days. You don't need to worry about it. But I ran out of it, so I use non-absorbable suture.
So, Pala.
Yeah.
So we have had this sort of problem, and we do it in a little different way. So it's also a bolster dressing, where we take typically a vial of heparin, empty vial, which is about 5,000 unit heparin, the standard vial. Cover it with sterile gauze, and then just put that and apply a tight dressing, no suturing, over it with Dynaplast. And that tight dressing would be similar to what a cardiologist would be doing after removal of the femoral artery dressing. That sort of tight dressing. And that's worked 100 out of 100 times. So we also have a bolster, but that's ready-made empty vial of an antibiotic or a heparin 5,000 unit vial. So that also works, and no suturing is required.
Right. So the only problem I've had when putting dressing like that, it will eventually wear off, no matter how hard you put it, because it's an elastic kind of tape. It will become thin. It'll thin out, and next thing you know, the dressing has bounced up like this.
No. So you have to pack it nicely all around the catheter exits, tunnel site.
Now, Hemant.
Yeah. Right.
The vial is a cylindrical object, and your catheter is also It's a round object.
Yeah.
So will it stay put on the top? It can slip and get
No,
to the...
that's what I'm saying. First you wrap it in a gauze piece,
Hmm.
a nice gauze piece. So that will provide the support. And then you take your dynaplast in such a way that from the skin, it goes all the way, almost beneath that whatever bolster you are going to put, come out on the other side, and that both sides will then secure it. It doesn't get slipped out.
I will call
I'm a little bit
call that,
skeptical.
I think I will call that a holster bolster.
No. See, if you take a suture at the exit site and the damn thing is bleeding in the tunnel, it's no sooner going to form an hematoma. It will not only be painful, but also a very solid site of infection. So
Right.
that's always a concern. So I want to just stop it. I mean, no bleeding within the tunnel, inside the tunnel.
Right. I think when you put the bolster dressing also, when there is no bleeding, that's fine. But if bleeding has already happened, we should not forget the venotomy. We should additionally put that pressure on the venotomy as well, because we don't want that hematoma formation.
But I mean, see, most of the time it's the venotomy, especially if you have exchanged the catheter over a wire. Then and if that site is big, the venotomy site has become big, then it will keep on oozing till you will, eventually it will bleed and then clot and something like that. The tunnel will clot.
Yes, Venki.
Dr.Adrian, nice crisp presentation, much like what I saw you doing there. So one question. So I feel like this exit side ooze is much common with certain catheter makes as compared to other. If I can name, like it happens very rarely to me with the palindrome. On the other hand, it happens to me every time with the bar hemo split. So it's relatively less with the glide path. I don't know if that is the experience with you as well, and what's your comment on that?
This first time I'm hearing this. I have seen it when I've put single lumen catheters for IV. I've seen bleeding happen with that too. These are softer, very small diameters, even smaller than this, single lumen, and it will bleed.
Venki, the glide path cuff is sort of conical. It is
as compared to the split, hemo split, you are right, sir.
Yeah, or the palindrome. They are.
But the hemo split, the bleeding is definitely there. So I'm seeing it almost on every case. So I thought like I just hear those observations.
We don't use a hemosplit, Venki. I like my go-to catheter is glide path. Now it is the pristine catheter, and so I have since I don't use hemosplit, so I don't know. But it's interesting your observation. I have to keep an eye out for it.
No,
So
Adrian,
make the.
Yeah. Yes, Hemant.
Yeah. No, see, also the tunnelers of different catheters are of different configuration. Especially the leading edge sometimes is very sharp as compared to very blunt in say palindrome catheter. So even that sharpness of the tunneler also matters. And if you happen to apply some force, which sometimes happens if there is already history of previous catheter and there is a lot of fibrosis, and you apply force, and if that happens to be a sharp pointed tunneler, I think the risk of bleeding is much more. And that's what happens, what Venki is referring to about one catheter over the other.
And Dr. Ajit Narula has asked, I missed your point on extravasating from the catheter. This is actually the discussion is on extravasation from the tunnel, the pericatheter area. Ajit Narula, you can unmute. Karthik, just unmute Ajit Narula and he can.
Yeah, so he mentioned something about injecting a dye to see the extravasation from the catheter. So I missed that point when he was talking about tunnel bleeds. Or did I get it wrong?
No, so here is what the classic story will be: the patient gets on dialysis and the bleeding is happening only at that time. And so one of the things we have to rule out is there a defect in the catheter? We have seen many surgeons or many radiologists here. Every time they put a catheter, they put a stitch at the exit site. We don't like to do that because we always have felt when you put a stitch there and you leave it, it is a focus of infection or a patient will develop an exit site. And so you can have somebody who's trying to put that stitch and nick the catheter. Well, once you put the heparin and you put the clamps, there's no flow. The bleeding will usually not be there, or there might be just a little bit of heparin coming out, but you would not see it because the gauze is in place. But once the patient starts dialysis, the bleeding will start. And so one of the things to always rule out is there a problem with the catheter? We should not forget that catheter. And the only way to figure this out, because that part that is nicked or has a hole in it is probably inside the tunnel, is to shoot dye and see if there is extravasation of dye from the catheter into the subcu tissue. That was the point I was trying to make.
No, Adrian, I'll add something more to it. We have had two patients.
You can unshare so that Girish can share and we'll continue the discussion. Yeah.
Bala?
Yeah.
So we have had two patients. One started bleeding after almost a year of catheter. Eventually, we could not figure out anything. We packed the tunnel with gel foam and whatever, took a suture, he would bleed. So ultimately, when we removed the catheter, about 1 centimeter away from the exit site, the catheter had developed a crack, spontaneous crack. I mean, no maneuver was done. So that was one. And second, I don't know how many of us are aware about this palindrome catheter with silver iron sleeve. So two patients with silver iron sleeve, the joint where the silver iron joins with the Y hub of the catheter developed spontaneous cracks on 2 occasions, and that would obviously bleed during the dialysis. So those are different issues. What Adrian is referring to is somebody trying to take a suture and making a nick deliberately, I mean accidentally. But this is something which is not done, it just happens. So defects in the catheter after several months or year of its existence is also known, not to be forgotten.
Girish, please share your screen and check.
Alex wanted to ask something. Alex?
Yeah.
Sir, hello. Sir, I wanted to share my experience only. Can I go ahead?
Yeah.
I had a scenario wherein there was a 19 centimeter hemostatic I inserted. There was ooze for 2 days, which got controlled with tranexamic acid and other thing, and then compression. But it started bleeding again after 2 weeks. There was a gap of 2 weeks where it was functioning well. And then after 2 weeks, it started bleeding again. And somebody has actually pulled a catheter, either the patient or while doing the dialysis. There was a little pull, and slightly the catheter was out by around 1 centimeter. After that, I did tried what sir has done, Adrian sir has done. I did the same, but I didn't apply a gauze or something. I did use 20 Mersilk. I sutured this thing and applied everything, whatever maximum I could do, tranexamic acid, Minir, and everything I gave. But the thing was, it started bleeding only when the dialysis was started. It did not bleed at any other time. It started bleeding, and there was a profuse bleeding when dialysis was started with a catheter, despite doing all these things. And then what I did is I put a left jugular simultaneously and gave a rest for around 3 sessions. And again, tried the same with the sutures and everything in situ, what sir has done. Still, it started bleeding. So I ultimately ended up removing the catheter, leaving the left jugular in situ. There was no crack or anything in the catheter, which could have led to crack or puncture or anything. So,
injury. This looks very much like a catheter injury. Only during dialysis.
There was actually no evidence of catheter. I actually thoroughly examined the catheter. Actually, there was no injury at all. Only the catheter was little displaced somehow, either during the dialysis or something. So after that, it didn't get controlled at all. So I ended up removing the catheter after around 3 weeks or something.
So Alex, did you shoot, when you took out the catheter, it's hard to evaluate just by looking at it. Did you take a syringe and inject water through it and see?
That I didn't do, sir, but nobody actually, after insertion, it did not happen. It was a delayed bleed after 2 weeks, and nobody would have punctured the catheter or injured it in any way while suturing or something. It's unlikely, I feel, that they didn't resuture the catheter also after that.
Right. So right, it's not the fact that somebody injured it. Sometimes, these manufacturing defects will happen, and this is what Hemant was saying, and we have seen it. Very rarely, we have seen where you put a PD catheter, it will just break. And we were like, this is so surprising. We have not even used PD, but the moment we start, the catheter is ruptured. So this is a manufacturing defect. And the only way to know this is to just shoot water through the catheter tip, through the hub with the syringe forcefully, and it will bring out something. That's the only thing I would suggest.
Okay.